I start in the name of Allah, the Lord of Mercy, the Giver of Mercy. I'm Dr. Muhammad Yusuf Hawan, and the consultant physician. This is our second part of this series of 4 lectures on localization of neurological lesion. In the first part, we discussed about localization in unresponsive patient. And in that series, and in that lecture, we discussed about the role of the cerebral cortex and the reticular activating system. The second part is localization of the lesion in a responsive or conscious patient. And for this, we'll divide our discussion on localization in anatomical levels and based on blood circulation. In neurological levels, in the central nervous system, there are 3 basic parts of the brain where we can localize the lesion: the brain cortex, the cerebral cortices, the brain stem, and in between the brain cortex, cerebral cortex, and the brain stem is subcortex. The brain stem, as you know, comprises of the midbrain, pons, and medulla. In addition to these, we'll discuss some briefly localization of the lesion in cerebellum and in the extrapyramidal system. And the peripheral nervous system, which will be the last part of our series, we'll discuss localization in the spinal cord, motor sensory neurons, nerve roots, peripheral nerves, neuromuscular junction, and muscles. We'll be including some parts of the spinal cord in this lecture as well, because these are integral part of the central nervous system. So you know this, the lobes of the brain, and the frontal lobe, and the parietal lobe, the temporal lobe, and the occipital lobe. The frontal, parietal, temporal, and occipital lobes. And as you know, we discussed in the first part about the cerebral cortex and the reticular activating system and their role in keeping us awake and alert, and damage to any part of the result of damage to any part of these systems. So today we'll discuss the localization in the responsive patient or the conscious patient. And this, as I mentioned earlier, this includes the localization in the cortex, in the brainstem, and the subcortex. Then the brainstem naturally will be localizing lesion in the midbrain, the pons, and the medulla. We start with a question. A 65-year-old man wakes up in the morning with the right-sided weakness, more marked on the right arm than the leg, and inability to speak. There are no visual symptoms. The question is, where is the lesion? Left temporal lobe, right temporal lobe, left frontal lobe, right frontal lobe, or left occipital lobe. Just pause the video, think over it for a minute, and we'll start with the discussion. And we'll come back to this question once we have discussed how to localize the lesion in conscious patient. Right. So the the anatomy, the basic anatomy of the brain is the 2 cerebral hemispheres and the cerebellum and the brain stem, and then down is the spinal cord. So the frontal lobe, the cerebral cortices are divided into the frontal lobe, which are marked red in this slide, the parietal lobe, the temporal lobe, and the occipital lobe. Below this one is the cerebellum, and then there's the spinal cord. If you focus on this slide, so there's 2 red area and the blue area. And the demarcation between these areas is what is called the central sulcus. The gyrus in front of the central sulcus is the premotor area. The premotor area. And the premotor area is the primary area. The precentral gyrus. precentral gyrus contains the primary motor cortex, where all the motor neurons lie down, and they control the motor movements of the opposite side of the body. And behind this central sulcus is this primary sensory cortex, where all the sensation from all parts of the body come through the thalamus to up to this area, and where the interpretation of the sensation is happening. In front of this, the motor area, lower part of the motor area, this purplish area is called the Broca area. And this is the area which is called the primary speech area, motor speech area, where the motor part of the speech is controlled in the Broca's area. And behind this one, there's the greenish area, is the vernix area. This is the primary, where the interpretation of the speech is happening. So you interpret the speech here, vernix area, and produce the speech in the motor area and the Broca's area. And then the occipital cortex, and then there's primary auditory area below the sensory area, where the hearing part of the sensory sensation is done. And then in bit more detail in this slide, you have the precentral gyrus, which has got the primary motor cortex, the postcentral gyrus, which is the primary sensory cortex, and the area in front of this is called the motor association area, the premotor cortex, and the prefrontal cortex. This is the frontmost part of the cerebral cortex is the prefrontal cortex. What is the function of this part we'll discuss in subsequent slides. Then behind the precentral gyrus is the primary sensory cortex and the somatic sensory association area, with different sensations are interpreted, visual association area. This is the vernix area, the speech, which understanding the speech and interpreting the speech occurs, and the Broca's area, the production of the speech, and the motor part of the speech is produced from this part of the brain, and auditory association area and the auditory cortex, and the visual cortex, as mentioned earlier. So this is the basic anatomy. So as I mentioned in the first part of our lecture, that the result of damage to the cortex depends upon which part of the cortex is damaged. To lose your consciousness, you need to lose entire cerebral cortex, both the hemispheres. But if the part of the cerebral cortex is damaged, that will result in some focal neurological signs, and that depends upon which part of the cerebral cortex is involved. And to understand that, you need to understand the anatomy of the cerebral cortex. So if something happened in the premotor cortex, there will result in the motor signs. And if there's problem with the sensory cortex, then the sensory signs. So we'll discuss in detail in subsequent slides. But remember, cerebral cortical lesions, if they occur on the one side of the hemisphere, you'll find the neurological sign on the opposite side of the body. So your right side of the body is represented, you're in the left cerebral cortex. Your left side of the body is represented in the right side of the cortex. There one thing we need to understand is the dominant hemisphere. So the speech area, the cerebral cortex, which contains, or the cerebral hemisphere, which contains the speech area, the Broca's area, the speech center, is the dominant hemisphere. Usually this is determined by the handedness of the person. The right-handed person, your speech center is on the left hemisphere, in the left part of the brain, left side of the hemisphere. And in most of the left-handed people, the speech center is on the right side, but some of the left-handed people have the speech center is represented in both the cortices. So if you keep this diagram in your mind, and if you do the neurological examination, you find some lesion, and then you can interpret those lesions depending upon which part of the cerebral cortex is damaged. May I mention here that this discussion is all about interpretation of the signs, this is not about how we perform the clinical examination. We assume that you are able to do the clinical examination, elicits the sign, and from those signs, you can localize the lesion in parts of the brain involved. So this is how the cerebral cortex is cerebral cortex works, and how does the relay the orders down to the functioning parts of the nervous system, or functioning part of other parts of the nervous system, and to the functioning muscles. So if cerebral cortex is cerebral cortex is represented, the body is represented on opposite cerebral cortex, and that depends upon the function that for the area in the cortex is it depends upon the number of function that particular part of the body performs. So if the look at this thing, the look at the face and the tongue, they are performing a bigger function. The hand is performing a much more function than the rest of the arm. The big area on the cortex is represented by the hand. And so, and the similar, the big part of the area is represented by the face and the tongue. If you look at this diagram, remember this one, the leg of opposite leg is represented on the medial side of the hemisphere. So if you just visualize the both hemispheres are lying in like this, and this is the leg part of it, represented on this part of the hemisphere. So any lesion, anything which can involve this part of the hemisphere will cause problem with the leg on the opposite side. But if some lesion is affected, because these two parts of the hemisphere are lying close to each other, any structural lesion which can affect both legs, both part of the hemispheres will affect both the legs and cause paraplegia. So your differential diagnosis of paraplegia starts with, the medial surfaces of the hemispheres. Any lesion like meningioma, so can affect and press both parts of the cerebral medial surfaces of the hemisphere and result in the weakness of both the legs. But if there is some vascular problem, so this problem in this area, which result in the weakness or sensory problem on the opposite side of the leg, or opposite leg. And these fibers, so these are cerebral cortex contain the motor neuron. I'm just talking about the motor part of the cerebral cortex now. So from the motor cortex, the neuron sends an axon down to this part of the cerebral cortex, subcortex, and then coming down to the cerebrospinal in the midbrain, and down to the pons, and down to the medulla. And in the medulla, most of these fibers decussate to the opposite side. Some of the fibers continue on the same side of the thing. So this whole track from, I just start from here. So this whole track, starting from the cerebral cortex, down through the internal capsule, down to the midbrain, down to pons, and down to the medulla, and decussation to the other side, and some fiber going down to the same thing. So this is called pyramidal tract, or corticospinal tract. This is pyramidal tract or corticospinal tract, and this is primary motor. These are the primary motor neurons, and they terminate on the anterior horn cells, and from the anterior horn cells, the fibers go through the anterior horn cell through the peripheral nerve to the effector muscles. So if you have a lesion here, so that will probably affect only the leg. But if you have the problem on the cerebral cortex, that will affect the trunk and the arm. And this, if the area represented by the cortex is a hand area, will have damage to the hand area, will cause damage to weakness of the hand, and this is the facial face area. So the cortical area, which is damaged, and with that the resulting damage to the part of the body will be this area represented there by that particular cerebral part of the cerebral cortex. But if you focus on this area, so these fibers just come together here, and they're quite condensed here. This is the internal capsule, and this is the posterior part of the internal capsule. The fibers are quite condensed in this part of the brain. So these are the corticos. This is the internal capsule cross section, and this is the area. This is the corticospinal tract or the pyramidal tract coming from the cerebral cortex. This part is represented up here. So any small damage here will cause dense hemiplegia, dense weakness of the opposite side of the body, the whole body, the entire body on the opposite side. So, but in up here on the cortex, the small area of the cortex will affect the some part of the body. But in this part, in the internal capsule, especially the posterior limb of the internal capsule, where the motor fibers are concentrated, so the damage here will result in dense damage on the opposite side of the body. Similarly, in the midbrain, its fibers are quite close together, and the damage in this part of the brain, midbrain, pons, and medulla can cause hemiplegia or weakness on opposite side of the body. But we'll see how can we differentiate the lesion from this part of the body, this part of the brain from the brainstem lesions. And so, and then the anterior horn cells from damage to the anterior horn cells will cause what is called the lower motor neuron lesion. But any damage from the cerebral cortex to the anterior horn cells is called upper motor neuron lesion. So if we see, so from cerebral cortex to anterior horn cells at the upper motor neuron, from anterior horn cell to the skeletal muscle or effector muscles is the lower motor neuron. So how can we differentiate? The first thing that this is the upper motor neuron lesion and this is the lower motor neuron lesion. Just focus on this table. So upper motor neuron will cause weakness, but there will be no wasting. While the lower motor neuron will be causing weakness with wasting of that particular part of the limb. So weakness, but no wasting, this is upper motor neuron. Weakness with wasting is lower motor neuron lesion. Tone is increased in the upper motor neuron lesion, but decreased in the lower motor neuron lesion. Reflexes are tender reflexes, like knee jerk, ankle jerk, bicep, tricep, these reflexes, brachioradialis. So these are exaggerated in the upper motor neuron, but depressed or absent in lower motor neuron lesion. The planters will be upgoing in upper motor neuron lesion, downgoing in the lower motor neuron lesion, and superficial reflexes like the abdominal and cremasteric reflexes will be present in upper motor neuron and absent in the lower motor neuron. So upper motor neuron lesion sign, meaning the lesion is from the cerebral cortex to the anterior horn cells, the short of anterior horn cells, and the lower motor neuron findings from anterior horn cells down to the effector muscles. So that is the first part of the clinical examination, which will differentiate upper motor neuron lesion from the lower motor neuron lesion. So the cortical lesion, as I mentioned, depends upon part of the cortex which is involved, and which is the dominant hemisphere, which means contain the speech area, or non-dominant hemisphere, which doesn't contain the speech area, the opposite, the other part of the brain, in which the speech area is not located. So dominant hemisphere will cause weakness on opposite side of the body. I mentioned earlier, the weakness on one side of the brain will cause the sign on the opposite side of the body. So weakness on opposite side, if the patient is not able to produce speech, there's no speech, which is affecting the Broca's area and the Wernicke's area. So I will just discuss the motor speech problem and the sensory speech problem in subsequent slide. So the speech problem and the weakness on the opposite side of the body, the dominant hemisphere, motor cortex. Non-dominant hemisphere, the hemi-neglect, the patient, the weakness, the patient on the non-dominant hemisphere, the weakness will be opposite side, but the patient will just be neglecting that side of the body, and there will be visual field effects, and the patient gaze preference. The gaze preference means the stroke patient looks toward the side of the lesion. So the patient looking toward the side of the lesion is probably, this is, if they're looking towards the right side of the brain, which is affected. The epileptic or the seizure focused patient gaze is towards the opposite side. So stroke looks toward the side of the lesion. Seizure looks towards opposite side of the lesion. So patient gaze preference will give you some idea which side of the brain is involved. So the prefrontal lobe, I mentioned the first side, the frontmost part of the cerebral cortex. This is the lesion in that part of the brain will cause contralateral monoparesis, because sometimes only small lesion will some part of the cortex which is supplying one part of the limb will be affected. So contralateral grasp reflex. Grasp reflex is a primitive reflex which is present up to the age of 2 years in infants, and this is inhibited subsequent development of the brain. But once damage to the prefrontal lobe will lose those inhibition and inhibitory control, and that the grasp reflex will reappear. So you just scratch the palm of the hand, and that will lead to the grasp of the fingers. So that is contralateral grasp, opposite side of the hand will showing grasp reflex, as is usually find in infants. Ebolia is lack of spontaneity. That means the patient normally we just do something spontaneously. So the frontal lobe will usually lose spontaneity, and there is, because urine continence control, continence because of the frontal lobe controls. The last damage to the frontal lobe, the prefrontal lobe, will cause urinary incontinence. The posterior lobe, I mean the cerebral cortex, the occipital cortex, so is cause the contralateral hemianopia, usually upper quadrant. They have posterior parietal lobe. I'm sorry, this is the posterior parietal lobe. So behind the cerebral sensory cortex. So cause homonymous hemianopia, I mean one part of the field of vision is you can't see that, we discussed in the optical nerve lesions. The color anomia, posterior temporal lobe will cause we can't name the colors. Visual agnosia, we can't recognize the thing which you can be seeing. There will be mild contralateral hemiparesis, a mild contralateral hemianesthesia with this problem, with the posterior temporal lobe problems. So speech area. So as I mentioned, that the Broca's area is the motor part of the part of the the part of the speech area, the Broca's area, which controls the motor part of the speech and affects the fluency. The patient will producing some words, but no fluency. The comprehension is in the Wernicke's area, and that means can produce the patient may be speaking fluently, but has no comprehension, no understanding what he's speaking. Repetition is the speech association area, the fiber connecting these two centers with motor cortex. So that affects the repetition of the speech. Right. That is from the cerebral cortex. So the brainstem localization in the brainstem region depends upon we usually get advantage of the localization of the cranial nerve nuclei. So the brainstem compares the midbrain, pons, and medulla, and most of the cranial nerve nuclei are located in this part of the brain. So it's quite been confusing for some students. That probably how can we remember localization of the cranial nerve nuclei? I've just focused to my what I'm talking to. So if you remember that the brainstem comprises of the midbrain, pons, and medulla, and medulla is the lowest part of the brainstem. There are 12 cranial nerves, and the lowest 4 cranial nerves lowest four cranial nerves, that means 9th, 10th, 11th, and 12th cranial nerves. Their nuclei lie in the medulla oblongata. The lowest part of the brainstem, lowest four cranial nerves, their nuclei are in the lowest part of the brainstem, that is medulla oblongata. So 9th, 10th, 11th, and 12th cranial nerve have the nuclei in the medulla. Middle part of the brainstem is the pons, and middle four cranial nerves, they are the fifth, sixth, seventh, and eighth cranial nerves, their nuclei are in the pons. And the upper two, the third and fourth, is the upper part of the brain stem, that's the midbrain, third and fourth cranial nerve. The lowest four cranial nerves, medulla, middle four cranial nerves, pons, next two, third and fourth cranial nerves in the midbrain, and first and second cranial nerves will go up to the olfactory nerve to the frontal lobe, and the optic nerve to the occipital lobe. So if there is a problem, if you find a clinical examination that there is a third nerve lesion, that means the problem is the midbrain. If there's fourth nerve lesion, the problem is the midbrain. So yeah, usually the lesion in the midbrain will cause both third and fourth nerve lesion. So I'm not going to tell you how to examine that, but I'll show you some of the features of the cranial nerve lesion. So if the 9th, 10th, and 11th, and 12th cranial nerves are involved, the problem is in the middle oblongata. 5th, 6th, 7th, and 8th cranial nerves are involved, the problem is in the pons. So how will you know? So in third, fourth, and sixth cranial, usually when you attach these cranial nerves together, the problem, your patient will have ptosis and will have double vision. So ptosis, double vision, other signs of cranial nerve. I'm not going into details or examination of the cranial nerves, but just remember the ptosis and double vision problem with the third, fourth, or sixth cranial nerve. Fifth cranial nerve is the numbness of the face. So it's the sensory trigeminal nerve. And there are some other motor signs of fifth, but I'm not going to know the details. Just briefly, seventh, weakness of the face, seventh nerve, hearing loss, 8th, 9th, 10th, and 12th will cause dysarthria and dysphagia. And 11th nerve will cause weakness of the shoulder and neck, sternocleidomastoid and trapezius. So examine the cranial nerve, find which cranial nerve is involved. Think about the nucleus of the cranial nerve, which part of the brainstem is the nucleus of the cranial nerve, and think of the localization of the lesion is in that part of the brainstem. So very simple. It's not very difficult. So localization depends on the cranial nerve examination on the brainstem, brainstem part of the brainstem, which part of the brainstem is involved. Depends upon the sign of the particular nerve involved. So we discussed the cortical lesions, we discussed the brainstem lesion. So in between the subcortex, so if you remember, this slide here. So I told you the subcortex here and this part of the brain and internal capsule up here. So any small lesion here will cause dense lesion. That means a very small lesion can cause very major neurological sign. And then, so this subcortex will have small licular part, very small in form, can cause, dense hemiplegia on opposite side of the body. The aphasia will affect the motor speech area. And apraxia is that you can have the individual muscle movements. You can move the arm, move the hand. But if you ask the patient, show me how you comb your hair, or you show me how you brush your teeth, they will not be able to do that. So that is apraxia. And then there will be visual field defects. Some part of the visual fields you will not be able to find thing or that there will be visual field defects and subcortical problem, depending upon which part of the temporal lobe or parietal lobe is involved. So upper quadrant, lower quadrant, hemianopia, that will be part of the subcortical lesions. Right. So from the motor cortex, I'm just going to the sensory system because this is just lying next to the motor system. So this is we mentioned about that previously. The motor starts from the motor system starts from premotor system, premotor gyrus, and the sensory will start on the sensory. But from sensation, usually start from the peripheries. So in the motor cortex, we start from the cerebrum and go down to the peripheries. In sensory system, we start from the peripheries, go up to the brain. So from sensation, from peripheral nerves, the sensory fibers. So there are two tracks which carry the sensory fibers. There's the spinal thalamic tract and the dorsal column tract. So, and the fibers from in the half touch, temperature, and pain. These fibers are these sensations are carried from the periphery and through the spinal thalamic tract, go up to the thalamus. But the dorsal column, the fibers, I'll start from here. It's not shown in this figure. So these are the half touch, vibration sense, and joint position sense. These are the sensations, and two-point discrimination. These are the sensations carried by the fibers taken by the posterior column. From these are the columns from here, up, from the cross to opposite side, going up, and again go to the thalamus. And from thalamus, these go to the primary sensory area. So, and if you know, the same motor area sometimes associated with some senses, the damage to the motor cortex, I mean motor tracts will damage to the sensory tract as well, and will lead to some sensory loss. So, but if you examine the sensory system, there is the touch and temperature and the pain. These are the sensations taken by the spinal thalamic tract, while the two-point discrimination, joint position sense, vibration sense, these are taken by, and half of the light touch is taken by the dorsal column. So the same, the spinal thalamic tract, the dorsal column going, the fibers, and later spinal thalamic tract, then going up to the thalamus and then to the sensory cortex. So sensory deficit will cause contralateral hemianesthesia, touch, pain, temperature, proprioception, two-point discrimination, and appropriate motor signs, any nearby motor tract or damage or injured. So one particular syndrome is called thalamic pain syndrome, and the specific problem with the thalamus will cause thalamic pain syndrome, and this is the usual reason is the stroke, and the findings are paresthesia, the tingling and numbness, allodynia, and other than just no pain. I mean, this patient didn't have the pain, but constantly complaining of pain in the opposite side of the body. Hyperalgesia, the patient has got small pain, but that will be exaggerated. So, and opposite side of the body is involved, and the entire opposite side of the body will be involved with thalamic pain syndrome when the damage this is in the thalamus. So, as I mentioned earlier, sensory tracts are the spinal thalamic tract and the dorsal column tract. Spinal thalamic tract that can carry fibers for the touch, pain, and temperature. The dorsal column carry fibers for proprioception and joint position sense, vibration, light touch, and two-point discrimination. So cerebellar lesion briefly. So any damage to cerebellum will cause uncoordinated movement of the limb and trunk, difficulty walking, including problem with the balance is called ataxia, tremors. Tremors, the intention tremors is typical of cerebellar lesion, nystagmus, central nystagmus, horizontal nystagmus, vertigo, something surrounding the environment surrounding Joseph, nausea and vomiting, intense headache, and ipsilateral signs. The signs are in the same side of the lesion in cerebellar lesion, while in the motor cortex, the signs are in opposite side of the lesion, opposite side of the body. So another system which is called extrapyramidal system. I mentioned the motor cortex from the cortex to the spine, anterior and the corticospinal tract. This is called the pyramidal system or pyramidal tract. The motor fibers which are not included in this pyramidal system are called extrapyramidal system. And the extrapyramidal system, it was called this fibers. The spot is the basal ganglia. So basal ganglia, this is the part around the lateral ventricle. Uh, the location is around the lateral ventricle, and it's so this the basal ganglia comprises of the putamen, the globus pallidus, caudate nucleus, lateral ventricle, substantia nigra. So these nuclei are called basal ganglia, and from fibers from peripheries to come to this system, and they send to the cortex. But damage to this part of the brain, or the basal ganglia system, will cause which the signs which are called extrapyramidal signs, and the extrapyramidal signs include the rigidity. So, cogwheeling, I will discuss it. Right. The rigidity, what is rigidity? And how does it differ from the spasticity? With the upper motor neuron sign or the pyramidal tract sign, like I mentioned, the tone, we mentioned about the tone is increased. But in upper motor neuron sign or pyramidal tract, upper motor neuron lesion or pyramidal tract lesion, the tone is increased in the flexors of the upper limb and extensors of the lower limb. So the patient, must have seen the patient walking with, I just want to show the patient just put the arm like this and circumducting the leg. So just flexion in the upper limb and hyperextension in the lower limb on the opposite side of the body. This is spasticity, and spasticity is sign of upper motor neuron lesion or pyramidal tract lesion. In contrast to this spasticity, rigidity, the tone is increased in all group of the muscles in both sides of the body. It may be asymmetrical, but is present in all group of muscles. The tone is increased, the patient is stiff all over, all the muscles and the arms and the legs. And this is called rigidity. And this is the sign of extrapyramidal lesion. So extrapyramidal lesion will cause rigidity. Pyramidal tract lesion will cause spasticity. So examination is very important to differentiate. Whenever you ask to examine the motor system, so you naturally look for and do the inspection, look for the wasting, fibrillation, and then you check for the tone. And when you check for the tone, you see the tone is increased in either one limb or both limb or all the limbs. When the tone is increased, you need to ask yourself, well, if the tone is increased, is it spasticity or rigidity? So in spasticity, tone will be increased in flexors of the upper limb and maybe unilateral, usually unilateral, but if the lesion is multiple lesion, then maybe the bilateral, but usually it's unilateral. So tone is increased in the flexors in the upper limb. So when you check for the flexion, it will be stiff, difficult to flex the thing, and then rigidity, and then suddenly it is giving off the stiffness, and this is clasp knife rigidity. Sometimes it's called clasp knife rigidity, but this is basically spasticity and sign of upper motor neuron lesion or pyramidal tract lesion. And similarly, you find in the increased tone in extensors of the lower limb, but in rigidity, all the group of muscles are rigid and stiff, and tone is increased in all group of muscles, so it becomes stiff in all what is, remove the, to examine the arm and the legs, and there is rigidity. So rigidity is of two types: is lead pipe or cogwheel. When the lead pipe means is the stiff in all grade of movement, all range of movements. So this is the lead pipe rigidity when stiff all over in all ranges of the movement. While the cogwheeling is when there is some jerky movement, you feel jerky movements when you check for the rigidity. So this is because of the superimposed tremors, which may not be apparent most of the time, but it is when you feel jerky movement on examination of the tone, then probably it's a cogwheeling. So these are the typical features of the extrapyramidal lesion. Tremors, we find tremor, the resting tremors is present in the extrapyramidal tract lesion, but these tremors are usually present in less than 40% of patients. Akinesia or hypokinesia, that means the patient is unable to or has feel difficulty initiating the movements. Gradually, it affects the mobility, and patient is bedridden. So most of the time, we find the people that saying that, oh, this rigidity, but there's no hypokinesia, and the patient is bedridden. So what else do you need to find a bedridden patient? He cannot initiate the movements, and he has akinesia or hypokinesia, and these all features are the result of basal ganglia. Right. Another question the short case you might find in your examination is which may be having the internuclear ophthalmoplegia. In this, what happens is that if you check for the extraocular movements, so there is adduction. When you move the finger and ask the patient to follow your finger towards the right. So the right eye will be moving the right, with the left eye will not be following to the extremes. So there is loss of adduction on the side of the lesion, but will be nystagmus in the other eye. So if you're moving the right, so the nystagmus in the right eye and loss of adduction in the left eye. And the lesion in the medial longitudinal fascicle, I'll show you the diagram in next slide. So, but accommodation is normal. You ask the patient to look away and then look towards the finger, and then just see the size of the pupil that will reconstruct the accommodation normal, but loss of adduction and nystagmus to the opposite side. And if the patient is young, this is a sign of multiple sclerosis. If the patient is old, think of like a stroke. So you might find some in the examination. The examiner will ask, examine his eyes, and you find the loss of adduction and nystagmus in the other side. So if the patient is young, think of multiple sclerosis. If the patient is old, think of like a stroke. Like this is the baseline, and the lateral movement opposite side is fine. This side, so the right eye cannot adduct fully, and the left eye are abducting fully, but it will be nystagmus in the left eye. So these are the what's called internuclear ophthalmoplegia, and I'll not go into the detail, but there's some lesion in third nerve and medial longitudinal fasciculus, like here. So this one, the lesion, the right medial longitudinal fasciculus caused this one, loss of adduction in this eye and nystagmus in this eye. So another very important slide when you are examining for the second cranial nerve, which can give you some important information. So, yes, 1 minute. Yeah. So if the lesion of the optic nerve will complete blindness, one on the same side, same eye. Optic chiasma will cause bitemporal hemianopia. Bitemporal, both sides. So it's called optic chiasma. But if the optic tract here, there is a homonymous hemianopia, one side. The lesion in optic radiation, upper part will cause lower quadrant hemianopia, and the lower part will cause upper quadrant hemianopia, and occipital cortex will cause contralateral homonymous hemianopia with macular sparing. So if you concentrate on this slide, so you'll find the lesion. So optic nerve, optic chiasma, optic tract, and then optic radiation and occipital lobe. So coming back to our question, 65-year-old man wakes up in the morning with right-sided weakness, more marked in the arm than leg, inability to speak, and there are no visual symptoms. So the right-sided weakness, the lesion in the left side of the brain. Okay, the left side of the brain is the motor weakness, and the speech area involved probably is the frontal lobe, left frontal lobe. Right. So yes, few parts. The patient has difficulty walking and slurred speech, ataxia with slurred speech, a different type of slurred speech, the cerebellar lesion. Patient's wife reported personality change and difficulty wording what he wanted to say. This is frontal lobe lesion. Patient has difficulty recognizing objects and often get lost. unable to find their way home, the parietal and occipital lobe. Patient has difficulty remembering significant past events and no longer enjoys listening to music, the temporal lobe. And remember, there is no substitute to clinical examination. If you've done a good clinical examination, there's no way you cannot localize the lesion in most of the patient. And that's all. Thank you so much for listening to this lecture. Our next lecture will be on localization of the lesion depending on the vascular supply of the brain and the spinal cord. And the last will be on localization in the peripheral nervous system. So if there are any questions, any comments, so this is my email. You are welcome to comment and ask the question and give the suggestion to improve this series. Thank you so very much. Thank you.